I'm letting students in now. Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask your questions in the Zoom and YouTube live chat boxes, and they will be addressed. Good morning, everyone. I'm honored to introduce our mentor for today, Dr. Jeffrey Oliver. Dr. Oliver is a fifth-year neurosurgery resident at the University of Maryland Medical Center. He graduated magna cum laude from Jefferson Medical College. He's currently completing a one-year enfolded fellowship in endovascular neurosurgery with a division of neurointerventional radiology. Dr. Oliver is also a great mentor, and he volunteers with the community. I would now like to request Dr. Oliver to start today's session. Thank you.
All right, great. Thank you so much for the introduction. Let's see. Can you guys see my slides okay? Great. All right, so today I'm going to talk about neurosurgery, which is my subspecialty of choice. Like the folks said, I'm a fifth-year resident in the Department of Neurosurgery at the University of Maryland Medical Center, and it's a 7-year program. So I don't have any financial disclosures relevant to the talk today, but I will say that there may be some discussion of devices which are off-label or experimental therapies. And so basically I have kind of 3 purposes today in my discussion. The first will be to provide a definition as to, what is neurosurgery and how does somebody become a neurosurgeon. Then I'll move into a section of cases where I'll present 5 representative cases throughout the various disciplines of neurosurgery. And then finally at the end, I'll just offer some resources for folks that are interested in learning more or hearing more about the specialty. And then we'll finish with the Q&A session. So many people have different ideas in their head when it comes to, what is a neurosurgeon. This is a former chief resident of mine. You can see he's got the loops on and the headlight on, and he's diligently focused. We certainly see neurosurgeons throughout the media or throughout, popular culture. Folks like, Dr. McDreamy or from the Avengers, and then, folks in politics or the media as well are neurosurgeons. But the reality is that neurosurgeons are, very special in that, we kind of branch out all over the place. We don't just limit ourselves necessarily to being clinicians. And so this is a multi-tool, but in some ways, we're very capable, or people in our specialty are very capable or very adept at things like being research scientists. They may be teachers, they may be, leaders in the community, or they may be leaders in, the global community. Many neurosurgeons also delve into entrepreneurship. They may invent devices or therapies for patients. And then some often spend time writing books, or contributing to, medical literature. And some of that probably comes from our founder. And so typically, who we consider to be the father of neurosurgery is Harvey Cushing. He was born in Cleveland, and his father was a physician as well. But he ended up kind of pioneering the field throughout much of his work. And he truly had an outstanding career. He was at Hopkins, he was at Harvard, he was at Yale. He, served during World War I as a physician and as a surgeon. And he had many, many famous trainees. Some of the ones in neurosurgery that, you may have heard the name Walter Dandy or Penfield, or 2, of the very important people that he trained. I believe there's somewhere around 22 chairmen of departments who trained under Harvey Cushing. In addition to his clinical practice and his teaching practice, he was a Pulitzer Prize winner. And in the class of autobiography, he wrote an autobiography of Osler, who was another famous physician. And so he really was a jack of all trades. And I think that's probably where this multidimensional nature of the specialty comes from. The reality is in neurosurgery, we treat a broad variety of conditions. And, this is not a definitive list of the things that we treat. But this was just me sitting on an airplane thinking from A to Z, what are the conditions, I can think of that neurosurgeons treat. So if anybody can come up with something for why, that would be, bonus points for you. But really, throughout the body, we treat a broad variety of conditions. And, folks in neurosurgery also spend time subspecializing, just like pretty much any surgical subspecialty. Our subspecialties tend to be trauma, cerebrovascular, and that is broken up into, two components: open, so surgically opening up the skull and accessing vascular lesions, or endovascular, going through an artery to approach these lesions. Spine surgery, functional or epilepsy surgery, tumor, skull-based surgery, radiosurgery, pediatric neurosurgery, and peripheral nerve surgery. The one thing that's I think is important about neurosurgery is just because you may be trained in one particular facet of neurosurgery, you still have a generalist mindset at many places. So, in many institutions, the spine surgeons will also cover peripheral nerve cases or trauma cases. People who train in open or endovascular neurosurgery may also cover tumor cases or skull-based type procedures. So I think that's really important in terms of one of the reasons I chose neurosurgery was that diversity of cases and the ability to, maintain a diverse practice. So I'll just go through some of the specialties. So trauma neurosurgery deals, with traumatic brain injury and spinal cord injury. And then there are also some long-term sequelae of those injuries. This is an example of a patient who's had a decompressive craniectomy for a traumatic indication. Cerebrovascular neurosurgery, again, these are congenital or acquired blood vessel disorders of the head and neck. And again, I discussed before, but you're either, open or endovascularly trained, or some surgeons are actually dual trained neurosurgeons who are able to, provide both services to their patients. And primarily the conditions that cerebrovascular neurosurgeons are dealing with are things such as stroke or blood vessel malformations, such as arteriovenous malformations or fistulas. And then cerebral aneurysm is one that is very popular as well. This is an example of a cerebral aneurysm treated at our institution. So you can see this kind of, outpouching at a bifurcation of two blood vessels. And this patient was treated with an open operation. This is a metallic clip, which is placed across the aneurysm, sealing it off from the circulation. Spine surgery is a very important discipline in neurosurgery. And deals with the management of a variety of conditions involving spinal nerves, the spinal cord itself. These conditions can be traumatic, they can be degenerative, they can include oncologic conditions or congenital or acquired conditions. And some folks estimate that over 70% of the cases that go to surgery for neurosurgery are actually spine procedures. So it's probably, the most common neurosurgery subspecialty. This is just an example of a spine patient. This on the left is an MRI scan showing a disc herniation, putting pressure on the spinal cord. This was a patient who presented with upper and lower extremity weakness related to this herniation. And then you can see a CAT scan as well, where there's some calcium within the disc as well. So these are the type of patients that spine surgeons often see and treat or observe as an outpatient. Functional or epilepsy surgery is another subset of neurosurgery. Personally, I think this is one of the most interesting and probably one of the most rapidly growing and changing subsets of neurosurgery. These folks deal with conditions like movement disorders, so things like essential tremor or Parkinson's disease. They're the folks that put in deep brain stimulators or other types of devices for treatment of those conditions. Epilepsy surgery involves working closely with neurology teams to identify seizure focuses and potentially resect them if possible, or offer other management strategies for those patients. This subset of neurosurgery requires usually a year of subspecialty training. And, like I said, it's rapidly growing and evolving. This is an example of a patient who has So this is intracranial EEG. So you may have heard of EEG, which essentially allows you to understand, brain waves in a patient. In this patient, to help further isolate exactly where a seizure focus may be coming from, the patient actually undergoes a craniotomy. So you take off a piece of the skull and you place these electrodes on the surface of the brain directly, and that can really improve your ability to localize where the lesion is, and thus, offer a good surgical plan for the patient if possible. Brain tumor or skull-based surgery are often lumped together. Again, these surgeons treat the plethora of both benign and malignant tumors that involve the central nervous system or peripheral nervous system. These folks may commonly work with ear, nose, and throat physicians. Approaches can use a microscope, a surgical microscope, or an endoscope. And we see things like pituitary lesions or acoustic lesions or meningiomas in this practice, amongst, of course, many other conditions. This is a right frontal metastatic lesion that may be taken care of by a brain tumor specialist. This is a pituitary lesion, which is causing the patient to have vision symptoms. And these tumors can actually be taken out through the nose in either an endoscopic or microscopic manner. This is an example of a microscopic resection. So you're looking actually up the patient's nose and going through with this device. It's a ringed curette after you've drilled away the bone that's between the nose and the pituitary region, and going in with this curette to remove and debulk tumor. And it can be, a really satisfying result for the patient. Some folks have almost immediate improvement of their vision symptoms. Radiosurgery involves the use of radiation therapy to treat CNS diseases. Examples of that would be proton therapy, cyberknife or gamma knife therapy. Often, this is not like an isolated specialty in neurosurgery. Often, folks in this work also as tumor surgeons or vascular surgeons. And we work hand in hand with the radiation oncology doctors as well to plan and treat these cases. Pediatric neurosurgery it's a very interesting subspecialty. It requires 1 year of subspecialty training. It's actually the only branch of neurosurgery that has a formal matching process, and it involves the treatment of congenital or acquired neurosurgical conditions. And you actually treat patients prenatally up into adulthood. Many pediatric neurosurgeons will follow patients into their 20s and sometimes beyond for these conditions. This is an example of what's called a neural tube defect caused by potentially a folate deficiency. It's myelomeningocele is the name for it, which you may have heard of, but essentially this is exposed neural tissue and has to undergo semi-urgent repair at the time of delivery. And so you can see, the delicate nature of the dissection here and working to cover the neuroplacode and then reconstruct the skin overlying this defect. This is often a surgery which is done in conjunction with plastic surgery as well. And then finally, I think this is the last one, peripheral nerve surgery involves treatment of the peripheral nervous system. So you may treat things like brachial plexus injuries, median or ulnar neuropathy. Personally, most folks I feel like that do peripheral nerve also do spinal surgery. But again, you're not limited necessarily to just being a spine or peripheral nerve surgeon. I think one thing that's really great about our subspecialty and about our field is that we constantly work with other physicians and other surgeons. Of course, the natural order of things is that you would work very closely with neurology, but other subspecialties that we work with are plastic surgery, ear, nose, and throat doctors. We work very closely with critical care or trauma colleagues. We work with radiologists, with orthopedic surgeons are also, able to take care of spine patients, and then of course oncologists. And this is not a extensive list. Certainly, almost any subspecialty in medicine is, giving me a call about a patient or a consultation, and we work very closely with everybody. I think that's a great way to get to know your colleagues, and also make sure you have people of different backgrounds looking at the same problem with different perspectives, and potentially coming with different or better solutions. So how do you get to be a neurosurgeon? It is a long journey. So medical school is 4 years once you finish your undergrad. Residency is 7 years. And then, if you choose to do a fellowship following residency, that can be 1 to 2 years. And then, of course, you're an attending for the rest of your life. Many programs are switching now to like a 6+1 model where you do 6 years of your quote resident time, and then your fellowship may be infolded within. In some cases, this can negate the need for an external fellowship, but many folks are still choosing to complete fellowships, formal fellowships in subspecialty training after residency. So you can see it can be up to 9 years of post-medical school training. So, my journey, this is not how I got into neurosurgery. This is just a funny comic, but I went to the Pennsylvania State University, where actually at the time they had a 6-year combined program where it was you did 2 years of undergrad and then 4 years of medical school. I did my medical school after those 2 years at Jefferson Medical College in Philadelphia, which was just, both of those experiences were amazing. I learned so much from the folks at Jefferson. And while I was at Jefferson, at the time, the curriculum was scheduled that you had 2 years of preclinical training, so your academic coursework, and then 2 years of clinic time. And during your third year, you get to choose surgical subspecialties. I always knew that I wanted to be some kind of surgeon. And it was during my third year that I did an elective in actually orthopedic surgery, and they split us into different subspecialties within orthopedics. And I did a spine rotation, and I became very interested in spine surgery during this time. And I remember speaking to one of the fellows about the possible outlets to doing spine surgery. And he had mentioned, to pay, very close attention to my neurosurgical time, which was actually my next elective time. And so, I went to neurosurgery and I enjoyed it. And of course, that got me thinking about, what I wanted to do with my life. I'd set up a lot of my early medical school research and things like that in orthopedics. So I did take a little bit of a pivot during medical school and then, chose to do neurosurgery after my third year time. During your fourth year, you have the opportunity to do away rotations. Unfortunately, last year during the pandemic, we weren't able to have away rotators, but I'm very thankful that that's back. So we'll have visiting medical students from other institutions to come. And like I said, I was a student at the time at Jefferson in Philadelphia. So I chose 2 institutions which were, going to offer me something new or something different in neurosurgery. I wanted to see the trauma experience at the Shock Trauma Hospital in the University of Maryland Medical Center. I was somewhat familiar with it, having grown up in Delaware. Knowing and being familiar with the name shock trauma. So I did actually rotate at Maryland as a fourth year medical student. And then I also spent time at Vanderbilt University. And again, I just can't speak enough of the way that folks treated me at both of these places. And truly I got to learn and see how neurosurgery was done across the country. And most folks do 2, but some people do 3 away rotations. And it's a challenging time because you're very busy clinically. But it's an opportunity for the programs to see you and for you to see the programs. And what the fourth year culminates in during March is called the match process. So after you interview at places, you submit a ranked order list of all the programs, from 1 to 15 or so, where do I want to match in order of priority? The programs are doing the same thing. And, this gets put into the NRMP, the match algorithm, and it spits out essentially a letter of a best fit match where you end up going. And this is actually a picture from my match day. These are a bunch of my classmates in the background. You can see all the smiling faces. This is my smiling face because I was happy to end up matching at the University of Maryland, which was, in my case, it was actually my first choice. I ended up in Baltimore. This is Fort McHenry. This is a nice view of the harbor. For my training. And so where I am now, I'm in year 5 of neurosurgical residency, and it's a 7-year process. We do have some exams that we take during the course of training. One is a written board exam, which you can take anytime, I believe, between years 1 and 5 for credit. There's also a newer anatomy exam. I personally didn't have to take that, but I think that's something that's now part of the curriculum. After residency, you do an oral boards process, and We rank and we select our residents based off really a combination of factors. We're looking at their academics, we're looking at their board scores, we're looking at their research experience, and then also, how they interview and what's the general feel for the fit for our program. So, and this is our curriculum. This is our current curriculum. So you can see throughout the 7 years, you really do spend time, even though it's a neurosurgery rotation, you spend time kind of all over the hospital. You spend time doing critical care, doing some neurology. There's 6 months during your first year of dedicated neurosurgery time. And then during your second year is really a core year for seeing the different subspecialties and managing them from a junior position. There's times where you're covering night float or call. There's times where you're covering primarily trauma. There's some elective time in there as well. There's time covering what we call neurointerventional radiology, which is the endovascular portion of the vascular service. And then you become a chief resident. And then again, we're restructuring our curriculum so that we have elective time at the end of the year. So we'll kind of, that's, a gist of the specialty of the different subspecialties within it. I'll kind of delve into some cases now so you can see kind of what the day-to-day looks like, and just, a couple of the patients that you may expect to see or be called about. So in terms of a day in the life of a neurosurgical resident, as a more junior resident, you can expect to arrive at the hospital sometime, 5:30, 5:45, sometimes even earlier, 5 o'clock in the morning, to do your pre-rounding, check the charts for the patients, get sign out. Sometime between 5:45 and 6, the chief resident will show up. You'll do your table rounds, and then you'll go round on patients. At which point you may split, and somebody will go to consent the outpatients for the day's surgery. There's a brief window in there where you may write your notes for the day. You may finish seeing some patients that you may have not had time to do in that first block of things. You may grab something quick to eat before the operating room, and then the OR case schedule is variable from day to day. One day you may be in like a 2 or 3 hour case, and then you have another 2 or 3 hour case to follow. One day you may be in like an 8 or 9 hour very complex skull-based surgery. So just as a general, let's just say you're doing 2 shorter cases. You may go to the case, then you may have some time off in between, like an hour or so for some floor work or lunch. You'll go to your other case, and then the afternoon consists of, maybe there's an extra case, maybe there's some floor work or afternoon rounds which need to be done. In general, you're usually signing out to the night float provider sometime around 6 o'clock p.m. and then you may get some personal or family time, dinner time, and then typically you'll have to get some reading or research done at some point. So it's a very busy day. They can be pretty long, but in general, the years do fly by. I feel like, just the other day I was an intern. The guys that are graduating, right now were second years when I started, and they were really instrumental, or I'm sorry, third years when I started, and they were really instrumental in teaching me, basic bedside procedures, how to see consults and things like that. And so, I can't speak enough highly of those guys, and also just how quickly this time goes by. So we'll get into some cases here. It's not really your friend, but you do carry a pager. So you get called all the time from the hospital, either the emergency department, the trauma portion. At one point, I think I changed my pager ringer just because it was creating such trauma from going off with such a shrill ring. But it is how we find out oftentimes about patients that are in the hospital that need us. So, the pager may go off and you may get a call, or sometimes, this is the shock trauma hospital. So this particular case will be a traumatic case. Sometimes you may even hear the helicopter flying over top of the building, and that may be what wakes you in the middle of the night to know that there's a transfer coming in, and it might be for you. This is the helipad, and it's pretty cool to go up there from time to time and just see the helicopters coming in, or imagining that people are being transferred from all over the state to come to this amazing trauma center that we have. This is a picture of the trauma resuscitation unit. This is essentially the workhorse of where the trauma patients initially arrive for their initial resuscitation. So they'll be seen by, in the back we have the trauma team in the back corner there. You have this amazing team of nurses, respiratory therapists, and then there's consultants who may be walking around the unit to see these folks with traumatic injury. So, the trauma team may call you, they may say, we have a 38-year-old guy here, he doesn't have any history, he fell from height, was working at a construction site. And then they'll offer what's called the GCS. They'll say he's a 251T, he's localizing on the left upper and lower, really not much movement on the right side, but he has a large non-reactive pupil on the left side. The right's normal and reactive. The rest of his cranial nerve exam is unremarkable. So this is a patient for many reasons you want to be concerned about without even looking at the imaging. Briefly, the GCS, what that is that's the Glasgow Coma Scale. So this is how physicians talk to one another, and this is how everybody pretty much reports patients to neurosurgery, so that we have some sense of a common language and ability to communicate with one another regarding the neurologic status and level of consciousness of a patient who's brought in. And there are three factors: there's eye opening, their verbal output, and their motor exam. And then in general, we say if the GCS is less than 8, you should intubate. That's a generalistic thing, but it's a nice rhyme and helps people remember when to intubate patients. In terms of eye opening, you can get 1 to 4 points. If somebody's awake, they're talking to you, their eyes are open, that's 4 points. If they only open their eyes to you talking to them, that's 3. And if you have to stimulate them with either a sternal rub or deep pressure, that may be a GCS of 2 or 2 points on the GCS scale for eye opening. For verbal response, again, you can imagine the range of patients who come in. Some folks are oriented, they're able to tell you why they're in the hospital, what's going on. Some patients may have no response. If they're intubated, we denote that as 1T. So somebody may be, like this particular patient, I think was a 251T. So they were eye opening to pain, they were localizing, and in the 1T, they were intubated. So obviously if they're intubated, they can't speak, they can't make words, that kind of thing. In terms of the motor response, that's graded on a scale of 6. So if they briskly follow commands, that's 6 points. If they're moving purposely towards a stimulus, that's 5. If they're just withdrawing but not localizing specifically to the stimulus, that's 4 points. And then there are different forms of posturing, which will earn you, lower scales for a motor response. So the lowest GCS you can have is a 3T. But 3T can mean many things. So this is the CAT scan for the patient that I described. So it's a little bit confusing in regards to actually the right side is the left side of the screen when you're looking at it, and the left side of the patient is the right side of the screen. So this is a left-sided, and you can see all this bright, this is blood here, and this is an epidural hematoma. If you can see, these dark spaces in the middle of the screen are called the fluid-filled cavities. They're called the ventricles, and they're pushed over to the left side due to the nature of this hematoma putting a lot of pressure on the brain. And so this is a patient you want to be very concerned about because this is a large collection. One reason you assume it's epidural is because of the shape of it. You can see it's shaped in a convex nature versus something that would be subdural or under the dura, the covering of the brain, tends to be shaped as a concave collection. Blood, which is new blood, is bright on CAT scan. So this is a bone window of the same patient. Again, you can see the nose. It's a little bit of a lower cut down. You can see the nose and you can see the eyes now. And you can see a skull fracture as well in the region of this, what we call an epidural hematoma. So that's the diagnosis. Again, it's a blood clot between the skull, between the covering of the brain. Usually it has an overlying skull fracture, and the artery that's injured is often the middle meningeal artery. And so classically, we teach that these patients can present with a lucid interval prior to decompensating. So they may hit their head and be okay for a while, and then they deteriorate very quickly. We do associate these kinds of injuries with being young and having a male age as well. In this particular case, this patient had a pupillary change and also a very large mass lesion. So they went urgently to surgery. And so we call this a code 1 surgery. We have a code system. There's essentially 3 codes. Many hospitals do it differently. They may call it A, B, or C, but it basically gives you a gauge of how sick the patient is. A code 1 case is somebody who needs to be in the operating room within 1 hour. Code 2 may be like 1 to 8 hours, and code 3 may be 8 to 24. And again, it all depends on the underlying diagnosis and how sick the patient is. So this patient goes urgently to the operating room for a craniotomy. You can see these are Rainey clips, which help to slow bleeding of the scalp. Patient's bone is taken off and the epidural was evacuated very quickly. These are cases where we're moving very quickly. We're not, stopping for much. This is actually a picture of what the bone flap looked like when it came off, right? So you can see this is the inside of the skull. And actually, this patient was so sick that we very quickly, after we moved the skin flap, we actually put a burr hole. You can see there's a little hole in the middle of the skull right over the largest portion of the epidural. And we, while one person was making the rest of the cuts to make the craniotomy, the other person was trying to suck out some of this clot in order to decompress the brain underneath, because we know that, in these patients, sometimes, every minute that they're under such pressure can lead to a really bad outcome. So this is a picture of the post-operative CT scan. You can see these fluid-filled cavities have shifted back to the midline. In this case, this was a craniotomy. So the skull was put back in place and secured with titanium plates and screws. And, this patient was extremely lucky. They did remarkably well. They recovered their GCS to a normal GCS, and their motor exam improved on the right side over the course of about 48 hours. And they were actually able to be extubated and discharged with some rehab. And when we saw them in follow-up, they were functional and independent, which is truly, for these kinds of traumatic brain injuries, it's a remarkable recovery. The epidural patients tend to do well when compared to patients with subdural hematoma. But we still, treat them, very aggressively. And like I said, this patient was really fortunate to have such a good outcome. In general, just a word on traumatic brain injury, TBI. It's responsible for roughly 60,000 deaths in the US per year and about 225,000 hospitalizations per year. So this does not include patients who come in, have a CAT scan, which is negative, but they still have traumatic brain injury. And I think that's probably an area that, we have a lot to improve on as surgeons, or, even as getting some help from neurology or traumatic brain specialists, and picking up these patients who have a traumatic brain injury without a CT finding, and how we can, better serve them and treat them, because they still have prolonged disability from these injuries. There are other classes of injury. I showed you an example of an epidural. I'll show you some other pictures here, which include intraparenchymal lesions, or what we call subdural hematomas, subarachnoid hemorrhage, or skull fractures as well. So this is an example of a subdural hematoma. This is, again, remembering that the sides are crisscrossed to confuse this all. This is a right-sided subdural hematoma. There's actually a little bit of subarachnoid hemorrhage as well. But you can see that whereas before there was a convex shape to the epidural hematoma, the subdural shape is concave. This is an example, I don't think this is the same patient necessarily, but this is a craniectomy. So in the prior patient, we put the bone back on because there wasn't a lot of swelling or injury to the brain itself. The blood was all on the surface or on the covering, but sometimes we have to do what we call an expansile duroplasty. So we graft to the dura, the covering of the brain, and this allows the brain to swell over time. And then after a period of time, sometimes 2 months, sometimes 3 months, sometimes even more, that swelling will abate over time, and we're able to put the skull back on. That's called a cranioplasty. This is what we call a chronic subdural hematoma. Behaves differently than an acute subdural hematoma, although sometimes acute subdural hematomas can turn into chronic subdural hematomas. This is older blood and fluid, and you can see the color of it is very different. It's not that bright color, it's old, and it's dark fluid. And these can be treated differently. Sometimes you can actually just do a single burr hole to wash these out. We're now doing embolization procedures for them. It's a very interesting disease process that I think we have a lot to learn still about it, but just in terms of imaging, it has its own nuances and treatment strategies as well. And this is an example of an intraparenchymal contusion, somebody who may have been hit on the head and has a temporal lobe contusion. And then this is an example of a skull fracture. I just included this case because it does highlight the multidisciplinary nature of the work that we do. So, this skull fracture includes part of the globe. So this patient would be taken care of by neurosurgeons, by ophthalmologists, and then also by plastic surgeons to help, get a good facial reconstruction for this patient. So that's it for the trauma case for traumatic brain injury. I can take questions now, or if you guys think it's better to wait until the end, it's fine. We have 4 other cases to show and then some other things, but.
Let me check the chat. I think that there were a couple of questions, but we can also save them till the end.
Sure. Yeah, that's fine. I think we can save them to the end and just keep moving.
Sounds good. Thank you.
Great. Thank you. Sure. All right. So that was your first consult of the day. Maybe that whole procedure probably took you an hour and 30 minutes or so. The whole process probably took you, 2 hours and 15 minutes, 2 hours and 30 minutes. And you're sitting there and the pager immediately goes off again because that's what happens in neurosurgery. So you get another call. It's the trauma team as well. They're calling you with a 52-year-old patient, motorcycle crash victim. They have some right arm weakness, sensory changes. The patient's got a cervical collar in place and they just got back from CT. And then we do what's called an ASIA examination. So ASIA is our spine examination for spinal cord injury. It's a scale from 0 to 100 for motor power. And then also there's the AIS impairment scale, which basically characterizes these lesions as A is actually the worst. So that's a complete injury. E is normal. And then B is somebody who has sensation is preserved, but no motor below the level of injury. And then C and D are separated by how much motor is preserved below the injury. So that's probably the biggest distinction is a D patient has 3 out of 5 power in more than 50% of the motor groups that are tested below the level of injury. So oftentimes when we get called about these patients, we just bring these forms down with us. They're helpful for not only research, but documentation purposes, and also just making sure that we examine the patient from head to toe and kind of get all these things straightened out. But you can see how you're going through and you're testing these key motor groups. So there's 5 in the upper extremity, 5 in the lower extremity that we're looking at. And then you're also checking things like the patient's rectal tone and sensation as well, and then sensation throughout the body. And again, this is the ASIA form makes it so easy. The front page is this, the back page is this. So if you have any question as to how to grade a patient, you can refer back to the classification steps. So this is the CT for the patient that I described. So this is C2 is the one that has the biggest body at the top, 3, 4, 5, 6, 7. So you can see at C6, 7, it's a little bit subtle, but you can see on the scan on the left that it's a little bit slipped forward. And then if you look farther out, these are called the lateral masses. You can see that there's a fracture here. Okay. And then this is an MRI. So, oftentimes if a patient has a spinal cord injury or, concern for something going on, essentially always we get an MRI scan to better understand, unless they have implantable hardware devices that's not MRI compatible. So this patient, you can see there's some disruption of this disc. There's some extruded disc superiorly. The spinal cord itself looks okay. There may be a little bit of pressure on it, but it really does not appear to be the big cause of the neurologic symptoms. This patient probably had complaints more from a radicular, so from the nerve root itself being injured related to the trauma. I think we sometimes forget, but spinal cord injury patients, we get imaging on them after the injury has occurred. So you don't see the maximum of the injury. So you don't see the maximum of how much, flexion or extension or distraction the patient has undergone. You can only see the sequelae of what that's left the patient with. So this patient's ASIA exam was actually, pretty good. They were a 98D, and all they had were isolated right C7 distribution symptoms, numbness going down to the middle finger, and then some triceps weakness. This patient was treated from the front. This is called an anterior. So anterior is the front, posterior is the back. This was an anterior cervical discectomy infusion. So we went in through the front, we took out that diseased disc, and then locked the patient in place. This patient then stayed in a collar for a few weeks after the surgery, got a follow-up CT, and then eventually was able to be weaned from their collar. In clinic, again, the collar was weaned, and the patient actually did really well in regards to neurologic symptoms. And at 6 months, they had essentially resolution of that numbness and of that weakness of the triceps, and ended up being discharged from our clinic. We do use many other devices to help take care of patients with cervical spinal cord or radicular type symptoms. This is an example of a halo device. You can understand why it's called a halo, because it's like a ring that goes around. These are skull pins which get fixated into the patient's skull, and these are for injuries that we may not necessarily want to manage initially with surgery, or sometimes patients are too sick to immediately undergo surgery. They may have like polytrauma, they may have multiple broken extremities, they may have other things going on with them that prohibits them from immediately going to surgery. So this is a way that we can stabilize some injuries in patients that might not be great surgical cases right off the bat. The other thing we do, not often with the halo device, but we use skull pin fixation, is we do cervical traction to help reduce spinal fractures that are resulting in what we call jumped facets or locked facets. This is an example of a patient who's had a more, I'll say more serious operation, probably a more serious injury. This is a corpectomy. So this patient is actually missing, we took out an entire vertebra body and the disc above and below. They're fused in place from above. You can see in the front, they still have a breathing tube because this is a high injury. The higher the injury is, the diaphragm, right, which helps you, is responsible for the nerves that, the diaphragm, which needs nerves to be supplied and for breathing, can have inhibition when you have high cervical spinal cord injuries. The saying from medical school is nerves 3, 4, and 5 keep the diaphragm alive. So if a patient has an injury above 5, the chance of them requiring tracheostomy or long-term mechanical ventilation is very high, versus the lower down the injury is, they have a better chance potentially of not needing that. This patient has also undergone surgery from the back. You can see, on the far right of the screen, there's some staples in place. This is a surgical drain, which is in place, and they've undergone what we call a laminectomy. So a decompressive procedure where we take off the posterior ring of bone to help allow the spinal cord to swell and, hopefully take all pressure off of it to allow the patient to potentially improve. So, those are just some examples, again, of traumatic spinal cord cases. They can be, quite involved, but just another thing you may get called about. And, it's an area of a lot of research, and folks are looking at things like stem cell therapy. They're looking at, different surgical options. They're looking at the role of MRI for predicting how patients are going to do. And I think that, it's just a really interesting area and something that, we still have a lot to learn in. And hopefully, the future will have some new regenerative techniques, because a lot of these patients, unfortunately, can just be quite debilitated from that. So congrats, you've gotten through 2 cases, but the pager's ringing again. We'll transition a little bit. So this is now the emergency department. So these are no longer, cases from the trauma center. This is neurology. It's the stroke team, and they're calling you for potential what we call the BAT case. So BAT is an acronym. It stands for Brain Attack Team. Just another fancy way we, like to make things fun in the hospital. It's a 58-year-old female. The patient has hypertension. They're also overweight. They're found to have AFib, that's atrial fibrillation, and they have acute onset left-sided weakness and neglect. The patient's last known normal was 3 hours before they got to the emergency department. They do what's called an NIHSS, which I'll talk about, and it's 15. The aspects, which is a measure on their dry CAT scan of if there's any early, what we call early ischemic changes, is a 9. So 9 is high, so that's a good aspect score. They have what we call a hyperdense right MCA sign. They are getting TPA. and they have what we call right M1 cutoff on CTA with good collaterals and no core. So what does this all mean? So what's TPA? TPA is our alteplase. This is our clot busting medication. It's given to patients who are candidates for them. This is an example of a contraindication or warnings checklist that can be completed before, but typically it's patients who present within 4.5 hours of onset who lack certain other contraindications to getting the medication. What's the stroke scale? So the stroke scale is a stroke severity scale. It's from 0 to 42. If it's 8 or higher, we generally consider those to be good cases for us to remove the stroke clot if it is what we call a large vessel occlusion. And there are subsets of categories in the stroke scale. They include things that are similar to the GCS, but they also take into effect things like facial asymmetry, limb strength in the bilateral upper and lower extremities, ataxia, sensation, language issues. So, patients can rack up points, very quickly if they do have what we call a large vessel occlusion. So what is the hyperdense MCA sign? So this is that dry CAT scan of the head. This is the right middle cerebral artery. You can see when compared to the left side, there's this bright clot within it. You can actually see also, interestingly enough, if you look at the patient's eyes, they're deviated over. I mentioned before that this patient had some cortical signs, which included neglect. So this is a CTA, A standing for angiography. So this is where the patient gets IV contrast, and then we look at the blood vessels of the head and neck. In this particular case, you can see that there's a cutoff here. On the left side, these vessels go out, and obviously it's not a video, so I can't show you how they would continue out and supply the normal parenchyma. But here, these vessels cut off here about what we call the mid M1 segment. So that's the middle cerebral artery. So you have two internal carotid arteries, which come up and split into the middle cerebral arteries bilaterally, and then you have an anterior cerebral artery, which supplies the middle of the brain. So this patient, again, has a cutoff of the middle cerebral artery, and that's one of those large vessels that we're looking at because that's something that we can go in and we can take it out. And so how do we take it out? We do a cerebral angiography. So this is a blood vessel study where you go through an artery in the wrist or an artery in the groin. You inject contrast dye, the same contrast dye that the patient got before, and you take pictures under real-time X-ray, and you look to see, is the occlusion number one still there? Because sometimes patients get the TPA and they recanalize, and you do the angiogram, and maybe they're not like clinically better right away, but you do the angiogram and they've recanalized and there's nothing for you to take out. That can make you happy or sad depending on what time of the night it is. Other times, the patient still has an occlusion, and we want to help these patients out when they're good candidates for it. And so this patient, you can see that cutoff is still persistent. What you can see here is you can see in the back of the head, there's still a lot of vessels there. In the middle of the head, there are vessels. That's the anterior cerebral artery, but there's this big paucity of vessels in the middle of the screen on this. This is a lateral film on the right here. And so we go in and we take these clots out. This is the clot that was extracted. The way that we go in is we go in again through these arteries. We navigate up to the occlusion, and you can either deploy a stent across them and pull the clot out, or you can use a combination technique, or you can do direct aspiration of the clot only. So this patient, I think we did aspiration only. We got femoral access. We're able to navigate up to the clot, and basically you apply suction to a special suction thrombectomy catheter, and you remove the clot. And in this patient, again, we got fortunate. I would say in the cases that we do, we're usually about 90%, 80 to 90% successful at opening up the occlusions when they exist. Of the patients that improve after that procedure, we're probably looking at 1/3 to 2/3 of patients who undergo the procedure improve. So I remember when I was a medical student, this was, probably like on the fort. This was one of the most, novel and, really impressive things that people were doing. And they would give these talks, and they would talk about what we call the Fab Five, which are 5 stroke thrombectomy trials that proved that this therapy works and helps patients avoid the significant disability that's associated with having a large vessel occlusion. This particular patient went on to get an MRI after the procedure. The MRI shows some stroke. So this is this white is stroke. Oops, sorry. This bright is stroke. This is called a diffusion weighted image. And this stroke burden in terms of ones that we do see is relatively small, and it's in a territory which is probably not going to cause many symptoms. And in fact, when we saw the patient, within hours after the procedure, this patient had a stroke scale of 0. They were essentially back to normal. So it doesn't always happen that way. Sometimes there's more of a delayed recovery. Sometimes, unfortunately, the patients do have larger infarcts by the time we are able to get the blood vessels open. But it can be extremely satisfying, as you can imagine, to take somebody who you know is going to be profoundly disabled from this stroke and help them out. And really, I think the folks that establish this as the standard of care, cannot be commended enough. We do have a reperfusion grade. It's called the TICI, which is thrombolysis in cerebral infarction, I believe, reperfusion grade. It's essentially 0 is no reperfusion, 1, 2 has different categories. So this was a 2C, meaning that it was open with some sluggish distal distal flow, which will improve over time in most cases. And then 3 is complete recanalization. So in the US, stroke in 2018, at least, this is from the CDC, was responsible for 1 in 6 deaths. Almost 800,000 people in the US have a stroke every year, and many of them are in people who have had prior strokes. So it's a huge population of patients, and it's patients that, as a neurosurgeon, you can have the privilege to help out. Stroke belt is commonly the southeast portion of the country, but you can see that, our friends in Delaware and our friends in Baltimore, often are high, have high rates of stroke as well. I wanted to include this picture. This demonstrates what happens in some cases where either the stroke burden is too much or the patient presents late and isn't a candidate for the procedure. But this patient had to undergo a craniectomy because all this dark brain tissue here is stroke tissue. And what happens over time is that tissue will swell. Sometimes it swells very rapidly, and the patient can unfortunately, have herniation symptoms similar to the patient we discussed in the very first case. And this patient may undergo what we call a craniectomy. And even though craniectomy can help patients avoid death or very severe disability, patients who undergo this procedure often still have very inhibited functional statuses. So, but they still, can be helped potentially by neurosurgeons. So really, stroke, I think of it as a neurosurgical disease. I think that the technologies are getting better and better, and I think that it's truly remarkable what we're able to do. But not only in the beginning of the patient's care, but also we're still responsible for caring for them, even if we aren't able to get them open, or if they present late. There are things you can control and there are things you can't control, and sometimes you just can't control how late a patient presents in the process. So that's it for the stroke case. Once again, you've done many procedures, but your day is not quite over yet. Pager's going off again, and it's the emergency department. And again, it's a 40-year-old patient who's found down, and this patient has an aneurysm. So we use 2 scales here. So we call it a Hunt-Hess 4, modified Fisher 3 subarachnoid hemorrhage. And they have what we call an anterior communicating artery aneurysm. So the Hunt-Hess classification, this is how we clinically look at patients. I think maybe one thing you may have seen as a theme through my talk is it's important for folks in medicine to be able to communicate with one another, and then also us to be able to communicate within our specialty how sick a patient is. So a lot of these, quote, legends in our field have laid out these classification systems so we can understand, how patients look when they present. But a Hunt-Hess 4 patient would be very stuporous, probably intubated with focal deficits, versus somebody who may have an aneurysm rupture. Just a small amount of subarachnoid hemorrhage may only have a mild headache. If you have just an isolated cranial nerve palsy with headache, that puts you as a 2. Patients who are really, really sick, really sick are a Hunt-Hess 5, and they may be posturing. They may be a GCS of like 1-2-1T or 1-3-1T. So, and then the modified Fisher scale, this is a scale of how much burden of subarachnoid hemorrhage there is, and I think I said this was a modified fissure of 3. There was not intraventricular hemorrhage, but there was dense subarachnoid hemorrhage. So immediately when these patients come in, you're looking at the CAT scan, right? You can see that there's blood in the interhemispheric fissure. There's some diffuse subarachnoid hemorrhage throughout what we call the basal cisterns. One thing that happens in aneurysm patients, if you look at these fluid-filled cavities, these are not significantly enlarged, but for a young healthy person, you can see the development of what we call temporal horns. You typically don't see the temporal horns develop in young patients unless they have hydrocephalus. And so in a patient with a poor neurologic exam who's had an aneurysm rupture, this patient gets what we call a ventricular drain. This is a procedure that we do at the bedside. And basically what we do, in fact, our interns and our second-year residents are completely credentialed and signed off to do this procedure, but using anatomic landmarks of the skin and the scalp and the patient's skull, we plan a trajectory and we make a small incision on the surface of the skull, drill through the skull, make a small opening in the surface of the brain, and then place this catheter into the fluid-filled cavities. So this is a well-placed catheter that was placed by one of my junior residents or colleagues, which is in the fluid-filled cavities. And what this drain lets you do is it allows you to measure pressure, transduce pressure, and then also treat intracranial pressure. So intracranial pressure may go up in settings of diffuse cerebral edema, or if there's a blood in the brain, or if the fluid is not getting absorbed properly, those kinds of things. And one way to reduce those pressures without having to take a piece of the skull off is to put in a ventricular drain like this. So this patient gets a ventricular drain, and they also get a CTA, just like the stroke patient. And then this CTA shows something abnormal. So this is the right anterior cerebral artery. And then this artery gives off the more distal anterior cerebral artery. And what we call this is it connects the the right and the left anterior cerebral arteries is the communicating artery. And you can see there's a big outpouching here, which is not normal. And that's an aneurysm. And there are many types of aneurysms. These are saccular aneurysms, which occur at the bifurcation or the splitting of blood vessels. And so these lesions can be treated with surgery. And I think I showed you some pictures early on of how we would go through into a craniotomy and treat. An issue with treating ruptured aneurysms in surgery is that the brain can be very swollen. It can be very treacherous to get in there, to navigate up there. So, and also if patients aren't doing, well neurologically, it can be, tough to justify putting them through like this very extensive procedure. Although ultimately we want to do what's best to secure the aneurysm, because if you don't secure the aneurysm, the rupture risk daily is probably somewhere on the order of 2 to 4% for a ruptured lesion. It might be even a little higher in some cases. So this patient went to interventional radiology, or it may have been a neurosurgeon doing it regardless, for an angiogram and then treatment with coils. So what we do is, again, we inject contrast and take pictures. So you can see this is the internal carotid artery coming up. There's the middle cerebral artery, which, again, this is the one that was occluded in that other patient. This is, again, the ACAs here. You can see how it's supplying both hemisphere across the communicating artery, and this is a bilobed, ugly-looking ruptured aneurysm. This is just another picture, a lateral view of the same thing. This is a 3D reconstruction of this aneurysm, so you can see how it has these two lobes here. So in this particular case, we offered coil embolization. These are working 2D views of the angiogram. This is before and after treatment. We didn't get a complete occlusion of the aneurysm, but we secured what we felt was the rupture point here. This is another picture, so you can see there may be a little bit of a residual aneurysm at the base, but the aneurysm is fairly well packed, and that should really reduce the patient's rupture risk for potentially a really long time. And in most cases, you may follow this lesion. I think this patient actually ended up recovering really well. And to be honest, like sometimes it's hard to know why patients aren't doing well when they come in. They may have presented and had a seizure. They may have hydrocephalus, and sometimes that just takes patients a while to bounce back from. But this patient did well after 2 or 3 days of diverting that fluid, keeping the pressure down in the brain, aggressively managing them. We managed the aneurysm, quickly with coil embolization. And in this particular case, they were a young patient and had a great improvement in their neurologic status. they actually clipped the residual aneurysm. And this patient did avoid what we call a delayed cerebral infarction or ischemia related to what we call vasospasm. So vasospasm, basically, if you have an aneurysm rupture, there's blood around the big blood vessels of the head, tends to peak around days 5 to 14, but these blood vessels can get very irritated by having that blood around them, or for a variety of reasons. We still don't understand all of those reasons. But these blood vessels can clamp down. And if you imagine the blood vessels clamping down, you reduce your flow to the rest of the circulation, and patients can have strokes, and that can cause a bad outcome after an aneurysm rupture. I've seen patients, unfortunately, who are doing really well a couple of days after their surgery, then they get into this vasospasm window, and they don't do so well. We do have some endovascular means for treating vasospasm. This is not the same patient. This is a patient who underwent clipping of a ruptured aneurysm. They had a contralateral or a different aneurysm, which maybe wasn't treated at that time, or maybe there was a residual. I can't recall for this particular case, but you can see how narrowed these vessels are. And that disease caused this patient to worsen significantly neurologically. And so what we do is you bring the patient back down to the catheter lab. You can inject medication, or sometimes you even can take a balloon up into these arteries and do what's called a balloon angioplasty to open them up and prevent them from having severe worsening afterwards. So I think that's it for the aneurysm case. And I think this is going to be our last consult. So this is, the pager is not going off. This time you get to see a patient in clinic. So not all our work is emergency work. We do work, a lot of our cases certainly come from the emergency room, but a significant proportion of things are not necessarily emergencies. Like brain tumors may seem emergent to a lot of people, but many of them are just stable or slowly growing over time. They can be managed as outpatients with steroids and things like that, and then we can schedule them to have surgery. A lot of spine procedures are elective procedures. This is somebody who you may see in spine clinic. This was a 38-year-old female. Of course, she had a small child and developed really bad back pain and left leg pain, and a little bit of progressive foot weakness after lifting her kid. She had 6 weeks of non-surgical therapy. Oftentimes for patients who have disc herniations, we offer them non-surgical therapy because surgery has risks. And, regardless of what kind of surgeon you may be in neurosurgery, we want to make sure that we're well able to tolerate that risk, and we're not putting patients at undue risk for having complications. So this patient had 6 weeks of non-surgical therapy. Well, I think I mixed up my it should say without improvement of her symptoms. We do a motor examination for this patient, similar to the Asia exam where you're testing lower extremity function. Power is graded on a scale of 1 to 5. This patient had a little bit of weakness with extension of the big toe. That correlates with potentially an L5 level of their radiculopathy. This is an MRI study. You can see in regards to this disc herniation, this is the L4-5 level, and there's a big bulging disc herniation, which is going to be causing pressure, which we'll see on the next cut. This is a sagittal view. You can see how healthy and happy these other discs look at the higher levels. You can see 3-4 doesn't look super happy. You can see there are some end plate changes as well, whereas there's darkness in part of the vertebral body below. There's some brightness, which can indicate these are called mobic changes to the disc, or to the end plate or the vertebral body above and below. So this is now we're looking kind of, you cut the patient across in an axial orientation. Again, the sides are flip-flopped. This is actually the left side, which has the bigger aspect of this disc bulge. And this is putting pressure on the traversing nerve root here. And this is, potentially something we can fix surgically. So this is a lumbar disc herniation. What it is it's extrusion of what we call the nucleus pulposus through an annular defect. So what that means is the nucleus is the central part of the disc. The annulus are these fibers going around. You can kind of understand and visualize how they would be oriented in this patient. And you can see there's a defect. These defects tend to occur posteriorly and laterally. They can also be what we call far lateral disc herniation, where they occur much more wider up there. The difference is that the level of the herniation, or the level of the symptoms. So if you have an L4-5 disc herniation like this patient, they have a central or paramedian disc herniation, their symptoms are related to the traversing nerve root. So that's the L5 disc root. If you had a far lateral disc herniation, that would be affecting the exiting nerve root. So that may affect L4. This patient, like I said, failed medical management. This is a patient who underwent a minimally invasive procedure. This is actually using what we call endoscopic dilators, and it's done microscopically. So we dissect down. This is actually bone that we're seeing here. This is called the lamina. So this patient is undergoing like a foraminotomy or a hemilaminectomy for disc herniation removal repair. This is a drill bit, so we're drilling away some of that bone. And what you see left here, again, I apologize, the pictures are a little bit hard to understand without being in the operating room, but this is yellow. This is called the ligamentum flavum, and it's the ligament underneath of the bone above the dura. And so that gets bitten away with a device we call kerrison until we get down to the level that we're working. And so there's a retractor in here now. So this yellow ligament has been moved away, and this is retracting the spinal cord, spinal nerve root. And what you see is this bright, this is the disc, and this is the disc bulge, the disc herniation. And now you can take that out with a pituitary rongeur. Sometimes they come out really satisfying. This one came out in 2 pieces, but sometimes they come out in one gigantic piece, and you can see the nerve and the spinal or the thecal sac be decompressed immediately. But this was a pretty big disc herniation, and the patients for these cases, they can do really well. They're discharged on the same day oftentimes. Oftentimes they have absorbable sutures, so they don't need like a wound check right away in 2 weeks. Oftentimes we recommend just gradual return to activity with a follow-up in about 6 weeks for just a clinic visit. They do have a risk of recurrence. Sometimes that's upwards of 5%, sometimes it's even more. If patients recur, it's not unreasonable oftentimes to offer another microdiscectomy, but for patients who continue to have recurrence, sometimes they have to undergo a fusion procedure. So I think that's pretty much it. Those are our 5 cases. So that's it. You're off call. Congratulations. You did it. You did 5 cases. You really helped a lot of patients. I'm going to transition just into offering some resources in the end of my talk, and then we'll get into the Q&A session. I think looking forward in neurosurgery, the future is just extremely bright. I can't say enough about what the outlook for this specialty is. There are definitely some common themes for things. I think that we're moving more and more towards more minimally invasive procedures, whether that's minimally invasive approaches to our cranial surgery or spinal surgery, and then also this idea of neuromodulation. I mean, I'm a surgeon, or a surgeon in training. I feel like at the end of the day, yes, I'm being, paid to do surgery, but at the same time, I want what's best for patients. And sometimes what's best for patients is no incision, or the best incision that you have to, follow up is when there's no incision at all. So one area of, neurosurgery that the group at Maryland has just been amazing with is this idea. It's called focused ultrasound. Basically sonographic energy. It's used in combination with MRI to non-invasively treat CNS conditions. And so there are many applications of focused ultrasound. Certainly I would never claim to be an expert in them. I've only seen one focused ultrasound case. But the applications that we're primarily using it for right now are movement disorders like Parkinson's disease or essential tremor, in which it can be used as an ablative therapy, where basically you can ablate certain tracts or certain deep nuclei by providing high focused sonographic energy to these regions, and patients can grossly improve in regards to their movement disorders. The other way it can be used is with as in an augmenting form. So you can augment the blood-brain barrier, and this may allow for improved drug delivery. And so that's an area of ongoing brain tumor research in regards to GBM, right? So GBM, yes, oftentimes the treatment for glioblastoma, a malignant brain tumor, is surgery. But, we know that despite the best surgeon in the world maybe taking out what they think is all of the tumor, there are still tumor cells which are there, which are infiltrated into the local tissue. So, we need to come up with better ways to deliver drugs, better drugs to, help these patients out, better therapies. And so maybe this will be, some way that we can do that. The 2 pioneers at our institution are Dr. Howard Eisenberg and Dr. Graham Woodworth. Those are former chairman and current chairman who have really, done a lot to treat these kinds of patients. This is an example of a patient that they treated with focused ultrasound using this kind of therapy. And it's done real time with MRI, so you can understand exactly how much you're heating the tissue, understand exactly, where you're lesioning, that kind of thing. And again, this is a multidisciplinary thing. It's not just the neurosurgeons by ourselves. We're there with the neurointerventional radiologists, and the neurologist may be helping to examine the patients through the course of the treatment as well. But again, there's no incision for this. And there's no radiation too. Another thing that, I specifically haven't, done this. I just came across this pretty recently in a paper I was looking at. This is neuromodulation. So this is called the stentrode. So what it is an endovascular stent. So similar to those aneurysms that we coiled, or the stroke that we took out, we're going through the blood vessel, but this is actually on the venous side into what we call the superior sagittal sinus. And it's a stent which allows for brain-computer interface with patients with paralysis. I think in the study I was reading, there were 2 patients that they did this in. So this is kind of a drawing of how this thing works. Basically, it's a stent which will allow patients with paralysis to, the stent gets placed in the sagittal sinus, which allows it to interface and with primary motor cortex, so that they can then control with eye movements and such. They can control a computer screen, so they can do things like online shopping, or some things that may significantly improve somebody who otherwise can't move their arms or legs, may significantly improve their quality of life. They may be able to work, who knows. I think this is just really exciting stuff, and I wish I knew more about it, but it's all, a lot of this is like research driven, and I'm excited to see what happens with these kinds of devices and therapies. So and again, I think both of these therapies take into account this idea of these are minimally invasive, and they're neuromodulatory, and they're helping patients with these diseases that we think of as incurable. So, and maybe there are things which we might not be able to cure, but we can certainly restore, and we can certainly provide really good quality of life to people if we continue to push the threshold. So. Just last thing, these are some resources for you folks. Obviously, I'm biased working at the University of Maryland Medical Center, but we have our webpage. We have a YouTube channel which has some surgical videos, which I definitely would encourage you to look at. Some of these cases are on there, so you may be able to see like clipping of an aneurysm or ruptured or non-ruptured aneurysm. There's some spine cases there. I think there's a pituitary case there. Those are free and available. We also have a Twitter that you can follow along. In terms of more general neurosurgery things, the global community in neurosurgery and like the established foundations in neurosurgery are just really amazing in terms of the information which is available and free and out there for patients, and also interested medical students or interested undergraduates who want to learn more about neurosurgery. And across every social media platform, these folks have videos for understanding what we do, understanding the procedures, the operations, the anatomy. I mean, as a resident, I'm using these things, almost every day to augment my understanding of cases that, I may not be able to see this case because, you can't control what comes into your hospital. You can only, treat, what is directly available to you. So it's great to be able to experience other people's, cases, and sometimes they're mistakes, but sometimes, they're great successes and things like that through these different groups and through the videos that they have online. One of my former chief residents has an article on Slate which talks about how a neurosurgeon works, which is another good resource if you guys are interested. I think this is during his time at Johns Hopkins doing pediatric neurosurgery as part of our curriculum. And then, of course, there are tons of books by neurosurgeons. I think Do No Harm was one of the earliest, Henry Marsh's book. But there have been many, many books. If you're in for a real treat, the Harvey Cushing book is extremely long. It's over 500 pages of very small text, but it does provide a really interesting glance at how the field got started and his history. It's a pretty incredible story. That's just one of many books written about him. So, and then just I'll conclude with 3 final thoughts. anybody who's interested in medicine, I went to medical school thinking for sure I was going to do orthopedic surgery or some kind of surgical subspecialty. But I didn't know until the end of my third year that it was going to be neurosurgery. I just encourage everybody to shadow and try to experience as many specialties as you can. Obviously, if you're on this call, it's because you're already, being proactive and doing that. But sometimes the curriculums may limit you to a certain time and duration within subspecialties. So, you should definitely seek mentorship and reach out to people in the different subspecialties. Personally, I sought a lot of mentorship in orthopedics and sports medicine before deciding on neurosurgery, but the folks in neurosurgery just really helped out and mentored me and, got me to where I am. And I'm still in the long road of residency, but I'm about to finish year 5 and really excited about the future. And then just the last thing is don't neglect yourself and your hobbies. The most important patient you take care of is yourself. And, if you're not mentally and physically happy, then you need to focus on yourself before you worry about all the stressors that come with trying to do these really. They're amazing and they're humbling. It's an amazing and humbling profession, but at the same time, we have to make sure that we take care of ourselves so that we can take care of our patients. And there's definitely more of a push in general in the field of medicine towards that and towards wellness, but people would do well to remember that, I think. So again, the future is bright. And again, in terms of taking care of myself, these are 2 of my co-residents, and one of me and Greg, one of the rising chief residents, ran the marathon together, and another guy ran half marathon. So we're still out there, trying to take care of ourselves as well as our patients. And then I enjoy cycling too. So anyway, thank you so much for the chance to share some of my experience with you guys. Really best of luck to everybody. And so we can open up for the Q&A session now.
Thank you so much, Dr. Oliver. We really appreciate you taking the time to really give us your life advice and everything that you went over, especially the case studies. We really appreciated it. So now we'll begin our Q&A session.
Thank you very much for that incredibly informative session, Dr. Oliver. My name is Hamza and I'm from New Jersey. And just like you went to a BSMD program, I'm going to a BSDO program with Seton Hill University and the Lake Erie College of Osteopathic Medicine in Pennsylvania. So to start off our Q&A, what are the most common neurosurgical procedures that you come across?
Sure. So I think in general, spine surgery is the most common form of neurosurgery. It's probably 70%, like I said, of the cases that we do. But I think that if you subspecialize in like cerebrovascular per se, you're going to be biased into like what kind of subspecialty you do. So if you're a cerebrovascular neurosurgeon, the things that you're going to see are stroke, aneurysm, arteriovenous malformations. Aneurysms are much more common than anterior AVMs. Stroke is, of course, very common as well. So from that standpoint, I think that you can have the power to influence your practice in terms of like if you want to see more of a specific thing, it's easy to subspecialize. But that is part of the reason why I saw an advantage to doing neurosurgery in general, is because I think that like you can maintain your generalistic skills in terms of like taking trauma call, taking whatever comes into the ER as a case, but also have the opportunity to develop an elective practice that focuses on the procedures that you're most interested in. So it's not like in becoming let's just say you become a spine surgeon. It's not like our spine surgeon may be on call this weekend and he may do 3 or 4 trauma craniotomy procedures. So we're not like limited necessarily to being our subspecialty. So even though, X or Y may be more common, many folks still maintain their generalist mindset and training.
Thank you for the answer. The next question we have is neurosurgery procedures are physically and emotionally rigorous. How do you manage your well-being in your day-to-day life?
Yeah, that's a really great question. Again, for me, it's exercise and, keeping really close with my friends and family. I think that also having a really great team is essential, and just having everybody on the same page makes the day a pleasure, as opposed to, there's not really a day where you show up and you feel like it's work. It's always an opportunity to, give back. And every now and then you do have to refresh yourself that these are patients and these are, people that you're taking care of. And personally, one thing that I've kept over the past couple of years is just a log of either exceptional cases or exceptional like life events outside of neurosurgery. So like if you're having like a really, rough day where you feel like maybe you can't see the end of the day or you can't see this or that, sometimes I'll go back to that PowerPoint and like, just refresh myself on like, something really good that happened, like a family member who wrote a letter or something that was really positive. So that helps you, maintain your both your composure and your emotional, like understanding of what's going on.
All right, thank you for that answer too. The following question is, what is the difference in the roles between a neurosurgeon and a neuroradiologist?
Yeah, that's great. One thing I don't think I touched upon as well, which I can talk about quickly, is that, we work a lot with other specialists, but we also, we have some territory which is crossed over with other specialists. And personally, I think it's really a great thing. For example, right now I'm doing a year of primarily endovascular neurosurgery, but at the University of Maryland, up until the past year, that was all of the endovascular work. So cerebrovascular coiling or stroke thrombectomies were done by interventional neuroradiologists who are neuroradiologists who are trained to do those kinds of procedures. And it's amazing working with those guys because I've learned so much more about understanding imaging and understanding like technique that I may have never learned if I'd only been trained by neurosurgeons. On the other side of things, now that we have a neurosurgeon who does that too, their perspective coming in and understanding like, somebody who can understand how easy or challenging it is to manage an aneurysm for, say, in an open craniotomy with microsurgical clipping versus endovascular management. Somebody who can understand both ends of the spectrum, I think, has a lot of perspective to offer as well. So I think that there is a lot of crossover between specialists and specialties. Spine surgery is another area of neurosurgery that we share. There are orthopedic spine surgeons. So if an orthopedist wants to become a spine surgeon, they'll do 4 years of their residency and then a 1 or 2 year spine fellowship. And then they can operate on the spine in a very similar way that we can. There are some areas which, maybe one may be more interested in than the other. For example, like intradural spine surgery tends to fall under the purvey of neurosurgeons more commonly. So I guess specifically in regards to neuroradiologists, if you're an interventionalist, then you will cover the spectrum of neurosurgical diseases for sure. But your treatment will be all in a minimally invasive way. If you're a neurosurgeon, you have the ability to look at a problem, see it, and potentially treat it in an open fashion if that's indicated for that procedure. We'll never totally eliminate the need for open surgical procedures. I mean, I don't think. Maybe, who knows, maybe I'll be eating those words 30 years from now, 40 years from now. But I think having the ability to do both is something that the pioneers in neurosurgery and also, the current leaders in neurosurgery have just done an amazing job with making sure that we are involved in the process of becoming minimally invasive surgeons, as opposed to giving it away and just saying, oh, well, the interventionalists can do all of that kind of work. I think for our specialty, it's really important that we, maintain our ability to control those and treat those diseases.
All right, thank you for that answer. That was very in-depth, and I think people will benefit from that. Our next question is from someone who asks, from your first case study, what are some other possibilities a 3T could indicate?
Oh, yeah, sure. That's a great question. So, yeah, one of the most common calls from trauma will be, I have a patient here who is a TBI and they're intubated and sedated, they're a 3T, they're not doing anything. And so that can mean one of a couple of things. Your GCS, right, your Glasgow Coma Scale should be, you need to wake the patient up. So if the patient's on sedating medications, or if they were intubated with paralytic medications, they're not going to be doing anything. right? So, as a neurosurgeon, sometimes I have to ask the anesthesia staff to give the patient a reversal agent if I'm really concerned about them, or I may have to come back and serially examine the patient. There are other things, right? This is trauma. So a lot of patients have alcohol or other drugs on board, and those can depress your mental status. Things like seizure can depress your mental status. So a 3T, yes, sometimes patients have blown pupils bilaterally and they're a true 3T. There's no alcohol on board, there's no sedation. They are, unfortunately, have had a horrible, horrible injury, and there might not be anything salvageable in terms of their brain injury. But I'm always, whenever I hear somebody's a 3T, we're always looking for ways to, make sure that they're truly that poor, or hopefully that they're better and there's another explanation for that. So.
All right, thank you for that answer too. Here's a deep one. How do you treat skull fractures?
That's a good question. Sometimes you do nothing. We do have indications for treatment of skull fractures depending on which kinds they are. If they are depressed to a certain degree, sometimes just for a cosmetic result, we can offer surgery. And it also depends where they are. So is the skull fracture on the calvarium? So is it on the top of the skull? Is it going to be something that's cosmetic? Is it pressing on a vital structure, or is there an underlying hematoma that's pressing on a structure? That might be operative. But if there's just a linear skull fracture, there's no depression, there's no cosmetic deformity or anything like that, we may manage that by not doing anything. And oftentimes we don't even follow those up in clinic. They will just, heal on their own, and that bone will heal on its own. Sometimes skull fractures are a little more complex. They're on the base of the skull. They can have associated arterial injuries and things like that. And again, basilar skull fractures tend to not generally be operative, but sometimes you can have basilar skull fractures, like the one picture I showed where there was a depressed frontal fracture that was affecting the orbit, that also was affecting potentially the roof of the orbit. And so that was a case that was surgical. And so that gets treated in oftentimes a multidisciplinary fashion. So for example, the case that I showed, the patient would have been brought to the operating room, and it also depends like how sick is the patient. So that patient probably was not very sick. They may have just had like a mild traumatic brain injury. So we could have brought that patient into the operating room in 2 or 3 days with the plastic surgeons there as well, with ophthalmology as well, potentially. And then we would do like a craniotomy and repair the dura. If the dura was torn, we could repair like the major, part of the calvarial skull fracture. But then oftentimes we'll work with the plastic surgeons, and they'll provide, the more cosmetic brow reconstruction. And sometimes they'll even, do all the skin work as well too for us. So yeah, it can be a really multidisciplinary case, which is fun. It's fun to work with those guys. They're always really interesting to talk to, and they have really unique perspective. And it's cool to see the way that they handle the tissues, which is much different from the way that the neurosurgeons sometimes handle tissues. So.
Thank you for that answer. Here's another question. Can stem cell treatment repair nerve damage and help reverse paralysis in spinal cord injuries?
Yeah, that's a really great question. I think that there are institutions all over the place. One place I can think of is the University of Miami, which I want to say they have a website. In fact, I was just in Miami recently for a conference, and they have a building, which the building on it, I think, is the Center to Cure Paralysis. And I think that's a center which is working on some stem cell type therapies. Certainly, I want us to be able to help as many patients as possible. And I would hope that those therapies have worked. If there were something that were definitive and such, we would be using it. I think a lot of those things are still in the research stages, but, I look forward to seeing, in the future, what kind of options we have to help those patients. The question is, will it be reconstructive, or will it be circumnavigating what's been damaged, if that makes sense? So, and I just, personally, I just don't know what that answer is. I'm in my training, and I'm not specifically invested in that kind of research, but those may be some good places that you could read more about those kind of therapies and what's been going on with those therapies.
Great. Thank you. It's time. Our next question comes from, do you come across pituitary adenoma surgery, and what is the prognosis post-surgery?
Yeah, it depends on what the lesion is, but for the most part, pituitary lesions are considered benign. And they can be a little bit institutional, like some places do them more commonly than other places. Certainly I've, scrubbed into, I don't know, probably 10 or 12 pituitary surgeries. They're always, very interesting cases depending on, who you do them with. And if you have ENT there doing endoscopic, like an endoscopic versus a microscopic exposure, in general, the prognosis is very good for pituitary lesions, though. They can recur. I can think of a handful of patients that have developed more refractory pituitary lesions, or they've recurred with like maybe they've gotten like radiation or something, and they've had like cystic components that then have to be drained in an open surgical way, or with like a shunt-like device into them. But that's really only like a handful of cases that I can think of. And it also, like anything else, it depends on the duration of symptoms. So like if somebody has a pituitary lesion and they have vision changes for, a week or 2 weeks, that might be different from somebody who's totally blind and has been that way for a year before they figured out, what was going on in regards to, a pituitary etiology. So.
All right, thank you for the answer. Here's another question. Do you plant a lot of medical devices as a neurosurgery resident?
Plant, like put in to patients?
Yes.
Or, yep. Yeah, so I think, I could be wrong, but probably shunts are the most common, like neurosurgery. Well, other than the spinal instrumentation, shunts are one of the most common, like implanted devices that we put in. But many of the diseases we treat have permanently implanted hardware, whether it be an aneurysm that you're putting coils into, or like a shunt that you're putting in to treat hydrocephalus, or spinal hardware, which sometimes you can remove spinal hardware after it's been in and the patient's fused, but oftentimes it just stays in. And sometimes you even augment it or extend the fusion up a level or down a level if they develop disease at the next segment. But technology and implanting devices and technology has always been just a huge part of the surgeries and the procedures that we do. Although we like to say sometimes that the best shunt we put in is the shunt we don't put in, because shunts can be a little bit finicky and painful.
Thanks. Thank you for that answer. We have 2 more questions from me. What is the difference between a CT scan and an MRI of the brain and spinal cord?
Yeah, so a CT scan uses X-ray and has radiation associated with it. An MRI uses magnets. MRI is a better study for understanding the parenchymal architecture, looking for things like stroke. CT is very good, and they are getting better. I think I saw a picture on Twitter not too long ago showing like the first CT image and just comparing it to maybe one of the ones that I showed today. It's just remarkable what we're able to visualize now on CT. The one thing CT is a little bit better for would be bone, like understanding bone, like fractures and things like that. You can visualize them better, but it does have radiation. So for example, in a pediatric patient who comes in with a suspected head injury, we're not getting CTs, we're getting ultra-fast MRIs. So just a couple of sequences of MRI to understand what's going on. So they both have their utility and are pretty essential, although, I do wonder sometimes about, we obviously all have concerns about radiation exposure. A couple of CTs is not like a horrendous thing for a patient to get, but it'll be interesting to see if there's going to be like a new imaging modality in the future that will totally replace CT. In fact, some of the folks that have trained me, were around when the first CTs came out, and just, I don't know, I had a moment one time when I was looking at a patient going into a CT, and I was wondering, like, one day this device is going to be obsolete and what an amazing experience like that's going to be to just reduce that need for radiation or have something better in the future. So, but those are the major differences between the two.
Thank you for that answer. That was good. And the next question for me is, do you come across anoxic brain injury as a neurosurgeon? And if so, what is the prognosis?
Yeah, we do from time to time. In general, there's not usually a role for a neurosurgical procedure in anoxic brain injury, but that's, general. Every case is a little bit different. Anoxic injury, to be honest, is my experience with it, although it's a little bit limited to my time when I was doing critical care stuff as an intern, is that it is pretty challenging to prognosticate. So to prognosticate for anoxic brain injury, oftentimes you're getting MRIs at certain intervals. You may send like spinal fluid labs every now and then, or blood labs to understand the injury. You may get EEG for a long duration of time to understand, what's going on electrographically, mechanistically, how are things functioning. But it can be a little bit challenging. I think that's one area where our neurocritical care colleagues, so these are neurologists that have spent 2 or sometimes 3 years training specifically in neurocritical care, have much more experience and are much better able to understand what's going on and provide some prognosis to the family. But there are a lot of diseases in neurosurgery, not just anoxic injury, but traumatic brain injury is another one where I think having better prognostic markers and tools and biomarkers for understanding how patients are going to do long-term will really help us out in talking to families, because today we can only present what we know, but who knows, maybe 10 years from now we'll be able to tell a family like, based off of this, he has an X number percent of being awake in 6 weeks or something like that. Or for a mild traumatic brain injury, we can expect you to have symptoms for 6 weeks versus what we have now, which is not as good, frankly.
All right, thank you for that answer. I would now like to request Zaid to ask our closing questions.
Thank you, Hamza. My name is Zaid, and I'm a rising undergraduate student from California, interested in pursuing and specializing in surgery in the future. Actually, we have a similar backstory. I'm currently interested in orthopedic surgery, but also have an interest in neurosurgery. So it's really interesting to hear how you went from one interest to the other. So the first question I had was, during neurosurgery residency, do residents get training for EEG and cortical mapping as well?
We do get, when we do our critical care time, we spend some time, reviewing EEG with them. Personally, I wouldn't feel comfortable interpreting EEG though. We have excellent epileptologists here who are able to, provide that for us. In terms of mapping and things like that, we do work very closely with the neurologists. I have not yet been to our epilepsy. Well, I shouldn't say that. I've been to it like once, but it was many years ago. But we do have an epilepsy conference, like a formal epilepsy conference, where for cases which might be considered surgical cases, the neurologists, neurosurgeons, epileptologists who are taking care of specific patients will meet together, and they'll review everything about the patient. They'll review seizure etiology, they'll review EEG. If the patient's had intracranial EEG, they'll review that. They'll review imaging findings. The neuroradiologist will be there and review imaging findings, looking for mesial temporal sclerosis, things like that. If what was I going to say? And if the patient's had a WADA exam, that's something else we do in endovascular neurosurgery. So basically what it is if you want to localize hemisphere dominance, you can inject medication directly into the carotid arteries and evaluate a patient's response on neuropsych testing. So we've done many of them this year, actually, in the endovascular time. And, they'll review all of these results from head to toe and come up with a game plan for how the patient should be treated if they're a candidate for resection of a focus, or if they need, there are other things that we have. One's called RNS, and then there are things like VNS, which are devices which are functional devices to help either when a patient has a seizure, help to abort the seizure or reduce, increase the seizure threshold, I guess I should say. So.
Thank you for that. Another question we had was, what do you think is the most challenging aspect of the residency, and why did you choose this specialty?
It's a great question. Yeah, so for me, it came down to a couple of things. I really enjoyed, working with my hands. I always kind of knew I was going to be a surgeon, right? And choosing between orthopedics and neurosurgery was what it came down to for me is I felt that the neurosurgeons were a little bit more invested in head to toe, the whole patient, if that makes sense. Like they didn't, there are excellent orthopedics who do manage their patient, like all aspects of their patients. I'm not saying that, but I did feel like the neurosurgeons maintained a little bit more of their medical degree portion of being an MD rather than just becoming a technician. And I felt that that was important for me. And then also, I think the patients that we see in neurosurgery, I mean, again, trauma orthopedics do see incredibly sick patients, but in general, in neurosurgery, like some of the diagnosis we deal with, right, like metastatic brain lesions, subarachnoid hemorrhage, traumatic brain injury, these are really sick patients. And I wanted to be in an environment where I was being really stimulated by taking care of really sick patients. So that's kind of how I chose. And the second part was what's the most challenging part of it? Yeah. I would just say, I mean, again, I don't look at it as like an extreme challenge because I think that, being a resident is such an opportunity to learn from, the people who are training me. I mean, they're the masters in the field, right? Like they've been doing it for, long periods of time, so I think it's such an opportunity to learn. Or even when we have new attendings starting, I can learn so much from how a new attending approaches, being a new attending, because one day I'll be a new attending. So I think from that standpoint, it's not that I regret being in a very long specialty, but it is challenging knowing that I have many friends from medical school who are attendings now, and I still have many years left, several years left of training. And, at some point in time, you want to become independent and you want to, be doing things on your own. But just, having the patience to do that is, it's important. But again, it's not really, I wouldn't say it's like a regret or anything like that. It's more of just, it's hard. It can be hard at times to see the end of the long road.
It's really interesting to hear because, the part of the reason I was considering orthopedics was because of all the hands-on and the, the kind of feeling of working with your hands. But it's interesting to hear how neurosurgery has almost more of that sometimes. So that's really something to keep in mind in the future. Another question I had was, given neurology is a growing and expansive field with much to learn, how do you stay up to date on novel treatments during training?
I mean, I think that's one benefit of the training structures that we have in this country is that, it's not, trainees are being trained at high level academic centers that are constantly bringing in and testing new technology. My attendings here are incredible researchers and entrepreneurs. And so I feel like in terms of staying abreast, I mean, just being in that environment and having, weekly grand rounds, conferences, going over new technology is a great way to remain abreast of what's going on. But the other thing too is, you have to read and you have to stay current with the literature and what's going on. And so we have other ways which we indoctrinated that into our culture through things like a journal club, or some of the resources I shared with you folks are ways that I personally stay up to date with some of the growing technology. And sometimes that's how I hear about new technology that seems really interesting. So.
Thank you. And for our last question of the session, how do you recommend that undergraduates can kickstart their careers as potential neurosurgeons? And do you know of any research opportunities that are available currently for pre-med students in the neurosurgery field?
Yeah, those are great questions, and they actually, almost tie into one another. I can tell you that, I think I had a slide on, how we choose our residents, and our residents are chosen off of a combination of factors, right? It's I mean, number one, there's fit in an interview, right? We meet the people and we see personality wise, are they a good match, that kind of thing. But at the end of the day, there are certain thresholds that you have to hit to go into a subspecialty. Now, it used to be that we used, I mean, my impression, again, I'm not specifically the one selecting people, but it used to be that we used our board exams during medical school as a way to set like thresholds for, like how appropriate is neurosurgery potentially for somebody. And because the board exam is a good marker of, I'm not saying it's like a marker necessarily of intelligence, but at the end of the day, to score a high score, you have to be willing to work really hard. And so we want people that are, it's a hard job and we need people who are willing to work really hard. I think that the scoring of that is being changed to a pass-fail system for one reason or another. And so we'll probably have to look more at scores in medical school and where you fall in terms of class rank to help stratify people in terms of in regards to academics. That'll be one thing. So I would say, every class that you take, every course that you take, just trying your best to achieve, the highest scores that you can, kind of thing. And then the other aspect would be trying to get involved in research. In general, I think that your research experience will be formed by where you are institutionally. So for example, if you are at an institution that doesn't have a, superbly developed neurosurgery department, maybe your ability to get involved in that kind of work might be a little bit more limited than somebody who may be at like a huge academic center. So you can reach out to folks at these other centers. And one example is like we just started a 1 year kind of like it's like a research fellowship. It's not for undergraduates, it's for medical students that are taking time off. I'm pretty sure it's only medical students, but basically where a student may do like 2 years of medical school and then take a 1 year like gap year to do some research. And that will help like boost their neurosurgical interest, understanding, and then also get them on some projects and papers and things like that. Personally, again, things have changed and I feel like it's like amazing to see the applications that come in. People are just so competitive and the research output that they have is incredible. But personally, most of my like research was in orthopedics. And so I didn't have like a neurosurgery papers or things like that. But most people I feel like are willing to overlook that and understand if you change your mind or if you are interested in multiple things, that's, that shouldn't be a hindrance. But again, another opportunity is if you're very committed and you're worried that maybe there's somewhere on your application that you're selling yourself short a little bit, like, I don't know, let's just say your grades are very good, but they're not like, the top or whatever. You may choose to take a year to bolster the research portion of your application. And then you can say, look, I wasn't the number one student in my class. Maybe I was number 5 or whatever, but and those are not real numbers. Those are just made up numbers. But I spent a year with these guys here, and that will get you really good letters of recommendation, and also will get you, publications or research experience to put on your CV. So.
Thank you so much, Dr. Oliver. Those are all of our questions for the day.
Great.
Well, thank you so much, Dr. Oliver. I'm sorry, Manahil. Go ahead.
Go ahead.
I was just going to say, we truly appreciate you taking the time to answer our questions. I'd love everyone to please give a warm thank you to Dr. Oliver in the chat box for this incredibly informative session.
Yeah, thank you guys. I really appreciate the chance to talk to you about something that obviously is very near and dear to my heart. And I love my job and I couldn't see myself doing everything else. So, many props to you guys for putting this opportunity together. And I hope you guys are learning a lot about the different specialties in throughout medicine. So
now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. And the link to the quiz is going to be sent in the chat shortly.
Many of our students have also expressed interest in pursuing a leadership position in teleshadowing. We do have positions open on our leadership page, as we strongly believe in extending opportunities to others. And I think that that link is also going to be sent in the chat as well. Now we're going to move on to the next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us on all of our social medias at TeleShadowing. I'm looking forward to seeing you all at our next session, which is on June 12th, next Saturday at 10 a.m. Eastern Standard Time, with our physician that's mentoring us in geriatric medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.